Hi, I'm Dr. Randy Martin with the Marcus Heart Valve Center at Piedmont in Atlanta, and I want to welcome you. I'm thrilled to be joined by my colleague, Dr. David Dean. David is the surgical director of our Advanced Heart Failure Initiative here at Piedmont, and we're both thrilled to be joined by Dr. Jim Long. Jim is the medical director of the Integris Advanced Cardiac Care Center in Oklahoma City. Thanks for joining us, Jim.
Hey, it's a great privilege to be here.
David's talked a lot about you, and having had a chance to listen to you talk, I can see why he's talked so highly of you. So we've had the pleasure of listening to you give some very interesting talks and educate us about pumps and all sorts of things. So, Jim, what is this current status, and I want David to jump in, with LVADs, both as a bridge to transplant and as destination therapy? Where are we today?
It's a very exciting era. Tremendous pioneering over the last couple decades. The first decade being one where we had to prove the concept just that we could keep people alive. The last decade, we've seen remarkable improvement in survivorships, now becoming comparable to transplantation. And the current decade we're in is one where we're going to address those remaining challenges that we have to truly get this technology that's good for earlier stage patients with heart failure.
David, David has done, as you well know, such a remarkable job here with our whole program.
It's spectacular.
I mean, it really
it's a very strong program.
Will we reach the point where, because of the limited availability of hearts, where LVADs will be destination therapy?
I think we are at that spot where they are destination therapy. I think it's, premature to see how long those pumps are really going to go and what costs they're going to be to the patients. I think Jim's point of, I did not practice during the proof of concept point, but I've been there for the last 15 years and understanding all the morbidity and mortality that goes with these pumps. But I've also seen tremendous things of patients living a lot longer, seeing patients back, 1 year, 2 years, 3 years, and 4 years after putting our pumps in. The second person we put our pump in is still living up in the mountains in Blairsville, and she comes down to see us kind of when she decides to come to Atlanta. But she's doing great, and likewise, so you're seeing longer duration of these pumps with, not so much morbidity.
Jim, I think David brought up a neat point, is that you and guys like you and gals like you that were at the early stages of this, I mean, that's, you obviously went through a lot with bad outcomes with patients, and patients went through a lot, and and I'm saying bad outcomes because there were bad outcomes. It's an interesting emotional and academic endeavor in those stages.
It really is, and it really represents what I think is the best in pioneering. You wouldn't start unless there were high risk involved in this. And I think we all felt, patients, all of us as caretakers, felt like we were doing something to push the envelope on behalf of patients then, but also on behalf of patients of the future. It was risky. But in reality, it was a lot less risky than not doing it, because the natural history of heart failure without intervention was so dismal, so compromising, quality of life just terrible.
Well, I mean, I think the reason I'm bringing this up, I think a lot of young physicians, young people in healthcare, and even patients don't realize what it takes, both from a physician, nurse standpoint and patient standpoint, to push this envelope. Let me ask you about something that I find pretty intriguing, and that's in patients who have LVADs in, the incidence of aortic insufficiency. How common is it, and what causes it?
Well, aortic insufficiency is a problem that allows inefficiency because you have cycling of whatever gets pumped into the aorta that falls back into the ventricle and then gets recycled so it doesn't get delivered to the body.
Right.
The good news is we can prevent most of it by catching it early and intervening and repairing the valve at the time we do the implant. So if we already have valve leakage at the time we're doing the implant of moderate degrees, we go ahead and repair the valve at that stage or deal with it in one form or another. Preventing it involves, I think, good medical management. Certainly blood pressure control seems to be a factor. But where we place the graft, what kind of flow patterns we have, how we allow flow through the valve on an intermittent basis, These are all things that are presumed to be a part of it. We're still exploring what the actual answer is to that. The good news is it's not one of the worst problems we face. It's one that we think we can manage our way through.
How common, David, how common is it? So if you had, does it occur, 3 months out, 6 months out? How common is it?
It's almost center specific to some extent. There are some centers that see a lot of aortic insufficiency, and then there's some who don't see much. We've seen probably maybe 4 or 5% of our patients have had it, and we try to manage it, as Jim said, during the implant itself. But if not, we've actually used percutaneous approaches for this, and our last patient actually had a TAVI done to it, and dramatically she went from heart failure to not heart failure in literally about 5 hours.
And the literature's got TAVI approaches, Amplatzer approaches, and all these things. So it's really, and when I was asking the question, I wasn't so much at the time of implantation, but down the road. So it's really doing all sorts of things, medical management, cannula placement, those sort of things.
To do your best to help exactly prevent the problem. But I love the creativity that's going into this. I mean, the approach that we had to take before was a complete reoperation.
Right.
A major challenge to it. And with the advances that are going on in the world of valve management, we can now enjoy much less invasive approaches to it. So my hat's off to you for pioneering that. I think this is really a great advance for that problem.
Jim, and David, where do we stand with LVADs? I mean, as I was mentioning, we're seeing so many people that might be 10 years out from mitral surgery or left-sided valvular heart surgery and now come back with severe TR, right heart failure. I really believe a lot of our cardiology colleagues just don't appreciate what's going on. These people end up with liver biopsies and all sorts of stuff. So are we at a place where devices, VADs, are going to play a role in right heart failure?
I believe so. We've underappreciated the impact of right heart failure. We get away with left ventricular assist devices, but I'm estimating in at least 10, 20, maybe even 25% of our patients, we languish with right heart support inotropes.
Right.
We fortunately don't require a lot of mechanical hearts in urgent use, but we'll take a lot longer for a patient to get through with long inotrope support, difficult ICU courses that could be made better if we had ways of doing two things. One is managing the right heart failure when it occurs with right heart pumps. But secondly is getting to those patients at a stage before their right hearts have decompensated. That would be the preferable approach. We'd love to see access to patients before their right hearts burn out, and then they become very difficult management problems if you don't put an RVAD in, or if you do, then you're adding to the additional burden with the technology.
And David, and I'm sure Jim, you too, if you're putting in a device and the patient's got moderate TR, you're going to go ahead and do annuloplasty rings at that point, or do something to the tricuspid valve?
Yeah, I pretty much, as long as the tricuspid regurgitation is moderate to severe or the annulus is markedly dilated, changing the geometry of the right ventricle, then I'll go ahead and actually ring that. Occasionally we see actually a fair amount of tricuspid regurgitation associated with the ICD leads and impingement, and so you'll have to get a little bit creative with that and make the leaflets work again. But I do think that it's useful to have a competent tricuspid valve. I think liver congestion is a big problem. And as well as down road of cardiorenal syndrome just associated with that, and I think changing that probably does help reverse the heart failure milieu that occurs.
We're seeing lots of people with multiple devices in there with TR, so I mean it's not only in the heart failure group but everywhere else. So I want to ask the two of you, put your thinking futuristic caps on here. So where are we going with either totally implantable LVADs or, the thing patients say, well, gee, can't you just make me a mechanical heart? So what's the future hold, the near future?
Well, anything we can do to improve quality of life by reducing the tethering, even though today's version of tethering is really minimalistic compared to what used to be.
Tethering you're talking about associated to the pumps and to the batteries and anything
external
that runs
that somehow has to run the device. And You know, in the original days of using total hearts, we had 400-pound consoles that people were tethered to by 15-foot cables. Fortunately, we're way beyond that, and everything can be hidden pretty much under sports jacket, and you can look pretty darn normal, but you still have a percutaneous
Right.
lead coming through the skin. It'll be a great day when we can eliminate that and have some marvelous technology that converts power to radio frequencies, sends it across the skin, captures the radio frequency, converts it back to power, and then powers the device, but doing all that without any direct connect from the outside to inside.
Total mechanical heart?
I think a total mechanical heart is kind of there. We've had it for a long time and really
Sure.
haven't done much with it. I think Doris Taylor's work with decellularization and matrix and creating designer hearts is really fascinating, and I think her work up in the University of Minnesota is something to watch, but again is probably 15, 20 years down the road.
But what you guys have done for the the patients who are in intractable heart failure has really been remarkable. And I think you make the valid point is that we need to identify patients earlier. And as in valvular heart disease, there are a lot of people in that sphere. I mean, medical therapies have made some tremendous advances. Interventional cardiologists are helping along. Surgeons are helping along. So there are a lot of people in this space. But I think it's going to be an exciting next 10 years or so.
It really is. We're not finished with the innovation. It's not gone yet, but we're getting closer to that end point. And I think you make a very good point about the complexities in this field and the unknowns yet. Honestly, the best way to deal with that is to bring multiple disciplines together and plan our way through this. I think that's the beauty of what's going on here at Piedmont is you have established a great multidisciplinary program where we can sit here and talk about valves with experts in valves. We've got rhythm experts, and we bring all this together. We've got surgeons, cardiologists, blood pump experts. We bring all that together. And we're going to address what is truly a scourge on America, and that is heart failure. Very expensive, very morbid, very mortal. But with good thinking, good people, good hands, good centers of excellence, we're going to address that.
Well, we deeply appreciate you coming and giving your expertise. And, people like David, who has made a tremendous difference here with our program and our heart failure patients and everything else. But certainly you being a pioneer in the field, we appreciate that. So thank you for joining us.
Thank you. It's an honor to be here.
Good. And thank you for joining us. We hope that you'll tune in and come back to see us often.